Welcome to the Arkansas AAP podcast. I'm so excited today to welcome Dr. Heather Young. She's going to join us today, and we're going to talk a little bit about a program called SetNet and about keeping moms and babies healthy when they may have been exposed to syphilis. Big topic today, huh? Welcome,
Yes.
Young. Thanks.
Yeah. Well, thank you for having me. I'm happy to be here. I'm Dr. Heather Young. I'm a pediatric infectious disease doctor here at Arkansas Children's Hospital. And one of the major parts of my job is helping take care of mothers and babies who have syphilis, unfortunately. And so, you know, this has been a big thing for the past about 10 years or so. At one point in time, like syphilis really was not, it's okay, let me back up. Back in the 1930s and 40s and everything, syphilis was a huge deal. Tons of people had syphilis. Then we discovered penicillin worked and killed syphilis. And suddenly we saw from 1940 on, like just rates of syphilis just absolutely falling. And we stayed pretty low. Then in the 80s and the early 90s, as we had the HIV epidemic come about, we started to see a little blip in cases and we had some rises in syphilis. And then after that, actually by 2000, we hit an all-time record low of syphilis in all populations across the United States. And so now you'll find a lot of physicians and other healthcare workers who trained during that time who never saw a case of syphilis during their training. And then something happened starting around 2013 or so. We started to see this increasing rise in rates of STIs in general, and they keep climbing, and syphilis itself starts to climb. So we have been seeing that, and I have to confess, like, syphilis is not easy. William Osler, who's one of the fathers of modern medicine, had said, if you can understand syphilis, you will know all of internal medicine.
Wow.
It's so complicated. In so many ways, this is a very fascinating organism, fascinating disease if you are a science and germ nerd like I am. Like, but basically, it's very complicated. The testing is really difficult to kind of conceptualize and everything, and the testing hasn't been around since 1906, so it's difficult, right? And so it was one of those things, like whenever I first came out of fellowship and everything, I was like, man, I hope I don't have to ever see syphilis. I don't. And then I came here and all of a sudden I'm in the middle of a syphilis epidemic. And I'm like, well, I guess I'm gonna be an expert because life life is making that happen, basically.
Well, I'm so glad you're here to help us break it down today.
Yeah.
And our goal with this podcast is really to help decentralize some of the information, to improve access to some of the experts like yourself, Dr. Young, and to really make sure that we are able to help any pediatrician out in the community have access to the knowledge and tools they need to help address some of the big things affecting kids in Arkansas. And
Yeah.
I'm really excited. I mean, there's been so much focus politically and with policy on moms and babies in Arkansas in recent years. I'm super excited about that. We've been working to help increase access to care for pregnant women, make sure that healthy babies are born, and make sure mom is taken care of before, during, and after the pregnancy and the delivery. And with this, I mean, this is an issue that maybe people don't like to talk about. I mean, it is a sexually transmitted infection. I wondered if and I know we've been really working together on this through a grant that Arkansas AAP received through the SetNet program. And I wondered if you could talk through a little bit about what SetNet is and why it helps to focus on the health of moms and babies.
Yeah. So SetNet it's from the CDC. It's a grant, and the overarching SetNet program has been looking, ever since Zika, really looking at risk factors for moms and babies and looking at all of these outcomes that could be related to prenatal exposures and the like, especially in infectious diseases. And since originally syphilis wasn't part of this, but then as this epidemic has increased and we've seen increasing numbers of babies with congenital syphilis, they've folded in syphilis as part of that. And in addition to just having numbers and looking at things, there's also all of these outreach activities, like helping with this podcast and other things
Yeah.
to try to help improve and get the word out and try and help make a difference and kind of in reducing syphilis and helping moms and babies be healthy.
I love that. One of the things I have done over the past few years as executive director of Arkansas AAP is I get to talk with residents who are in their second year usually.
Mhm.
And every time I chat, it's usually a small group of residents on their community or advocacy rotation, and we sit down and we talk about, what are the things, if you had a magic wand, what are the things you fix, what are the things that keep you up at night about kids' health and well-being, and what are opportunities you see. And several of them came to me and they shared that if they could fix one thing, it would be congenital syphilis. And that was when I really started to notice that this was something that our residents were seeing on a regular basis, a regular enough basis during their training to say that this would be a thing I would fix
Oh,
over
yeah.
of all the things. So I'm glad that we're here talking about this today. I
Mhm.
wondered if I know I have seen when we did our webinar as a chapter, when we had the health department on to talk about this, I know they showed some maps with some kind of scary looking projections of the spread from kind of the Southwest across the country. I wondered if you could walk us through the data a little bit on congenital syphilis so we can know a little bit more about what's happening.
Yeah. And if you don't mind, I'm going to share my screen
Yeah.
and
And for
let's,
those listening, we'll try to walk through this in a way that you can
yeah.
hear and visualize in your own head.
Yep. So, are you able to see that on your screen? All right.
Am.
Okay. So this is a graph from the CDC that talks about congenital syphilis among rates per 100,000 live births in Arkansas and the United States. So you can see if you go down here in 2017, Arkansas was a little bit above the national average. You're looking at, less than 50. Whoops. Sorry, my mouse is very sensitive. Um, around 2017, we were less than 50 cases per 100,000 live births, kind of tied um, with the national rate. But then as you see, as the years have progressed, you see this divergence. So like basically the rates are going up in the United States, and we're now about up to 100 per 100,000 live births, but Arkansas is about 180 per 100,000 live births. So we're both are still on the upward trajectory. It's just that Arkansas is going up a little bit higher.
Yeah.
Or not just a little bit. I'd
Yeah.
say it's more like a lot higher.
Almost double. Yeah.
Yeah.
That's a lot.
Um, so um, this is a recording or a little animation showing the rates of congenital syphilis throughout the United States for the past few years. And let's see if I can make it go, darker blue is bad. And we'll say that Louisiana at first was really dark blue, and now more and more of the states are getting to be a very dark blue. So it's scary. Like this is going on widely throughout the United States, but Arkansas, we're ranking high when we don't want to rank high.
Right.
Um, yes. So that is kind of what's going on comparing us to nationally. So, you know, um, it's it's not that we are the exclusive problem, but we are definitely higher than we want to be in the United States.
And how is that? Do you have data on how that looks across the state, like regionally in the state? Do you have any data on how that breaks down?
Yes. So here I'm going to share my screen again.
Good. Yeah.
Share. Here we go. Share. So most of these cases, now this is by year, so each color is a different year, but we have all these case counts of congenital syphilis by region, by public health region. So, the majority of cases have been in the central part of the state. But again, these are absolute case counts. These aren't rates.
Right.
So in the central and northwest regions, that's where we've seen the majority of cases, but but that's also where our big population centers are. So in the
Yeah.
Northeast and the Southeast, those numbers are lower, but our population is also smaller. So I don't have that as far as a rate per se.
That's
So
great.
yes.
But if I'm doing the math right, and we're close to 200 per 100,000, that's what, 1 in 500 babies who's born with congenital syphilis. And we have around 35,000-ish births a year, I think, in Arkansas. So we're not looking at small numbers here. So
No, I mean, our absolute case count I think I might have this number. Let me scroll through real quick. No, I may not have it, but sorry. Um, we've been averaging about 65 babies with congenital syphilis per year
right,
for with the health department. So and you're like, oh, it's only 65 babies, but it used to be zero.
right.
And that's the important thing.
Well, what should a pediatrician know if a pediatrician is caring for a baby that they think might have the possibility of having congenital syphilis? What should they do?
Yeah. So the big thing is any woman who is admitted, and it does not matter, you cannot base anything off of risks. People will say, well, they're not high risk for syphilis. Well, if you look, the studies have shown that about a third of women with syphilis have no perceived risk factors for syphilis. It's sexually transmitted, right? Well, you to conceive a child, most of the time you're having sex. So that is from, and this is the infectious disease doctor's bias, like everybody's having sex, even when they say they don't. Like we
Yep.
just don't do risk-based screening. We just screen everybody. So
Okay.
every woman who shows up to labor and delivery, they're supposed to be screened at birth. They're supposed to be screened early in the or late in the second trimester, and then they're supposed to be screened at delivery. Because even though if at the first trimester they were negative, well, they probably had sex since the first trimester. You got to check, and they can get infected during their pregnancy.
Right.
So you got to check mom's records, make sure she got screened. If mom has a positive RPR, which is the test for syphilis, then you got to look at the baby.
Okay.
And most of the time, when a baby is born and they have been exposed to congenital syphilis, they've been exposed to syphilis, they could have zero symptoms when they're first born. They can look totally normal. And so you can't be like, oh, there's this weird number and I just don't believe it. And, this mom, like, no, there's no way she has syphilis. And I'm just going to blow this off. I'm not even going to, you can't do that. I've actually had several kids where people got some labs and didn't believe them. And they're like, nah, that's not real. And then the kid comes in and are usually if they are going to get sick in the first 2 years of life, they get sick at 6 weeks of age or so is when they first start to show signs and symptoms. So baby can be born and be totally normal, but the disease itself can be devastating. And so don't just blow them off. Definitely,
So it's go
yeah,
ahead. No, go ahead. Don't blow it off. So, and that's at the time of delivery. So let's say that for whatever reason, we did not the baby didn't have a test at delivery, but then what should a pediatrician be on the lookout for if it is like, for example, that 6 weeks later and they come in, what kinds of symptoms should they be looking for?
yeah. Well, I would say if you're seeing any newborn in your clinic and they were born at, they were born, at Baptist and now you're seeing them in, your Conway, clinic or something like that, like be sure to double check
Yep.
and make sure that you got those records and make sure that all the appropriate screening was done whenever you see them for those, well child visits. But then usually it's a very insidious onset. Usually there's a bit of failure to thrive. The babies are just kind of they're whiny and they're fussy and they just one of the big signs will be they seem to hurt and it's not a very concrete thing. Like people just kind of just seem like the baby just seems off.
Right.
And the parents sometimes say it feels like anytime you touch him, he hurts. And that's because the bacteria goes into the bones and can cause a periostitis and they'll even have something called a pseudoparalysis where their bone is so inflamed the baby won't want to move their arm or leg or whatever. So it
Wow.
looks like they're paralyzed in that arm, but no, it's just that they don't want to move it, kind of thing. They will get something called the snuffles, which is a thick white snotty nose. I mean, and it's real thick and gross. And in fact, it can kind of turn bloody. So they'll have that. The other thing is particularly a rash. They're usually like little round copper colored patches all across the body, but they'll involve often the hands, the palms of the hands and the soles of the feet, and they'll also peel a little bit. And so that is a very classic manifestation of congenital syphilis. And they will just be fussy, and you just look at them, you're like, this baby is just not right. But they don't necessarily seem to be totally sick. They're just like, there's just something wrong with this child. You can do lab testing, including especially an RPR, but they'll get a hemolytic anemia, they will be thrombocytopenic, they will be leukopenic, their liver will be inflamed. I've had plenty of them. We have huge livers and huge spleens.
Oh,
Um,
wow.
and yes, the pseudoparalysis and the rash. And then they can have neurologic features as well. It can go to the brain, it can cause deafness, it can cause infarcts and cause brain damage. So it's nothing to blow off.
Right. Wow. Okay. So let's say we do find syphilis. You're in practice, you have a 6 week old, these things all happen. What is, I guess, just at different ages, maybe it is at newborn or somebody comes into your office. What is the treatment?
So we admit them and they get 10 days of IV penicillin.
Wow.
Yes. So they are in the hospital. And that's, a lot of the times when babies are born, we'll look through all their risk factors and was mom treated or not. And in the nursery, if we know that enough and say like, hey, or we don't know enough and we just know that we need to treat this baby, we'll keep the babies in the hospital for 10 days, even
Okay.
at birth, and
Wow.
treat them with IV penicillin to be sure, there's never been a treatment failure from 10 days of IV penicillin. So you're giving
Right.
this baby all this penicillin to kill all these germs as quickly as possible. So that can also though be disruptive, right? So you've got a mom who's got her baby sick and in the hospital or can't come home from the nursery and has to be treated for an infection, and everybody at home is asking why, and it's time away from any other children she might have. When the mom comes in, I'll say whenever we've had parents, here in the hospital, I've been very quick. We've got great connections with the health department to get the mom connected to somebody who then can take care of the mom and give the mom her shots of penicillin, and all of that. And so we try and expedite that to get that done while we treat the baby. But
Great. So mom doesn't have to stay in the hospital. She just gets shots.
right.
Yeah.
So that's kind of one of the beautiful things. The only time a mom would need to have IV penicillin is if she had neurosyphilis for some reason. And that for usually you have a headache or there's telltale signs in an adult, not so much for babies. So for adults, you just get shots of penicillin in your rear, honestly, and you can do those as an outpatient. So it's to everybody's benefit to make sure to test the moms during and watch them closely during their pregnancy and make sure that they get access to the treatment and make sure they get it in them. And the goal is to get the treatment in the mom by 4 weeks prior to delivery. So that way it has time, the penicillin also has time to incubate in the baby and protect the baby as well.
Well, I'm super thankful that you are there to help care for babies when they are born with syphilis. I'm going to ask you an upstream question now, just kind of
Okay.
thinking upstream. How can pediatricians, OB-GYNs, family practice doctors, how can all the folks taking care of young adults and young adults and even adolescents in our state help to make sure that we are reducing the rate of congenital syphilis?
Well, it's silent for the most part. Syphilis can be very silent until suddenly it's not. And so the big thing is screening everybody. And if you have anybody who is pregnant, make sure that they get screened all of those times. Talk to them about what it is you're testing for. It's good to point out you're not discriminating against them and saying like, oh, I think you could have it. No,
Yeah.
just like everybody could have it. If you have had sex,
Right, it's universally recommended during
recommended.
pregnancy, yeah.
Yeah. Um,
What about even upstream from that? What about during an adolescent visit? What can a pediatrician do during an adolescent visit to help open the conversation about, just being safe and keeping safety out front?
Right. So, I mean, we encourage that with with every adolescent visit. It is recommended for all adolescents starting at age, I think it's 16, don't hold me to it, to go ahead and do STI screening just yearly, whether or not they say they're sexually active or not, because adolescents sometimes don't disclose, even if you have the greatest relationship with them. And so definitely screening for syphilis throughout this entire time. It is a simple blood test. The ES can be sometimes kind of tricky and wonky, but if there's a positive and we know how to go after it and see if it's real or not. But if you never do it, you'll never find it until it's too late and too catastrophic. So being out there, being open, talking to adolescents about, ways to protect themselves, it's hard to have those conversations. Sometimes it's hard to ask the parent to leave the room so you can talk to them about talk to the patient about about these things, but we should.
Yep. That's such a great point. We have our conference coming up, and I'm super excited. We have the theme is from puberty to parenthood, and really thinking about what's happening for girls and young women, and keeping them safe and being ready for adulthood. And one of the things that we're working on through that conference is a conversation around confidential care for minors, and how to put that in place as a routine part of your office visits for adolescents, and how to make sure that parents understand that this is part of helping a young adult be ready to take care of herself when she turns 18 or
Yeah.
older. She's ready to do that on her own. So I'm really excited about some of those conversations ahead too.
Yes.
Well, I guess just to kind of wrap us up here, thank you so much for sharing all this with us. What if you had a couple other resources that you would like to share just for moms and babies if they are concerned they have syphilis, if they do have syphilis, what direction would you point them?
So I would say for mothers, the health department or any adult, basically, if you go to the health department and you're worried, they will screen you and test you, and they provide the treatment. And so, and then if somebody's identified, so say you have a partner who's identified, they will trace that partner and will contact you and say, hey, we need to, you've been exposed, we need to do some investigations and the like. And they have a lot of resources that is really beneficial. Sometimes people have transportation issues, or sometimes they just have, and they have people who really, we used to have this saying at Children's called crossing the creek. You really cross the creek for this patient. Like they have people who will cross the creek to help make sure you can get there and get what you need. And so I would really rely on them. Of course, any of their people's physicians, um, they can go see their physician, whether it's their OB-GYN who ought to be well knowledgeable about this, or their other primary care doctor. And then if those people have questions, because I'm not going to lie, syphilis is tricky. It is not easy. There's adult infectious disease doctors who help deal with this all the time. And then for children, there's pediatric infectious disease doctors like ourselves. Like here at Arkansas Children's, we have a provider online from 8 to 4:30 every weekday just to answer calls from community pediatricians about what do I do with this kind of wonky case. And we are happy to help and answer and figure things out for you.
I know it's so great to have folks like you that are just like a phone call away. Thank you so
Mhm.
much for doing this. I also believe AAP has made the Red Book available online uh,
Yes.
to folks, and I think that's a really exciting. The Red Book for infectious disease. That's I know such an important resource, and having that. Yes, that one.
Yes, I have it, and you
Oh,
can
you have it
see
dog
how
eared.
I have dog-eared it. And yes, syphilis is definitely one of the larger marks. And I will say also for this edition of the Red Book, they've made an interactive algorithm. So for syphilis, if
Yeah.
you're a provider who's out there and you're like, I don't know what to do with this baby, you plug in these numbers into this algorithm and it kind of helps tell you what to do. So for providers, I highly recommend that resource.
Awesome. Well, wonderful. Well, Dr. Young, thank you so much for being part of this collaboration with you guys and with the health department on SetNet, and thank you for being willing to chat with us on our podcast today. We will go ahead and sign off, but thanks again, and y'all out there, holler at Dr. Young if you have questions. She is such a good help. Thanks again.
You.